When you introduce essentially a foreign receptor on the surface of the patient's own cells, and our study uses T cells collected autologously. There are studies in the future that are planned that will look at allogeneic T cells, and those will be T cells collected from other donors that might partially be matched but would be an off-the-shelf product. Our study used autologous, in other words, the patient's own cells that were engineered to express this B cell recognition site. Because we're giving cells that are not 100% the patient's own once they're engineered, we need to clear some space so that the cells, when they're infused, are not recognized by the subject as being foreign and don't induce a significant immune-associated reaction for the purposes of self-defense. We do that with lymphodepletion. We suppress the immune system just a little bit, again, so that we can clear space, and so these cells reinfused into the patient, which are mostly their cells and recognized mostly as self, still can have space to not be attacked so that they can gain a foothold and so that they can begin to expand so that they can be effective. The the primary lymphodepletion regimen that's been used in most studies in this new field tends to use cyclophosphamide and fludarabine, or what's been called Cy-Flu, as the lymphodepletion or conditioning regimen. We didn't do that in that study, in our study, for a number of reasons. We used bendamustine, which is an alkylating agent, but bendamustine is, we thought, a little better tolerated, not so much associated with hair loss. So we thought it would be good or more comfortable for patients to consent and proceed. But mostly we did this to minimize the risk of potential cytopenia. Bendamustine, we think, is a little bit more mild than the Cy-Flu regimen. And there have been cases of fludarabine-associated white matter changes of the cerebrum of the brain in some of the pediatric literature that's not, to our knowledge, been associated with bendamustine. Finally, one more thing. Both cyclophosphamide and fludarabine is closely associated with another molecule called cladribine that have been used and found to have some impact on the natural history of multiple sclerosis in previous trials. And so we wanted to try to minimize that potential confounder with using an agent that was more specific.